And we are live on Facebook now, I believe. At least I think so.
32 people there. Look at that.
It seems to be working. So I'm just going to double check on our Facebook feed over here. And we will be starting in just a moment. Please stand by. And I don't know why I never, yes, we have people viewing on Facebook now as well. Good evening, everybody. Welcome to the HCMA Presents, the HCM Strong Tour, Big-Hearted Warriors Unite. This stop, New York City, and a lot of other places as well, because obviously we're coming to you virtually. So I think we were supposed to do this meeting in May, and it was one of those ones that was canceled early on, and we figured we would come to you in a different fashion as soon as we could. So I'm going to stop sharing my screen for a moment, and I'm going to start the meeting by introducing a couple of people who you may not know so well, and those are members of the HCMA staff. And I'm going to move my screen over here so I can talk to you all. Okay. So I'm going to go by length of employment. I'll go that way. So Valerie Venturi is our Center of Excellence Coordinator. And Valerie has been working with us for 2 years now, I guess it is. Wow, time flies. And she coordinates all of our Center of Excellence applications and communications with our COEs. And now they get to actually meet her more in person here. Amy Mann is a fellow warrior and is our meeting coordinator. And we were originally supposed to be traveling the country together doing this tour, but instead we meet on Zoom when we can. And Amy works to create the meetings, the structure, and we're working on our 2021 plan. God help us, we get out of 2020. So we're looking to next year's planning. So stay tuned to the website for Amy's upcoming events. And last but not least, our newest addition to staff, Julie Russo, who is our volunteer coordinator. So any of you who are watching who are interested in participating in any of our efforts and our volunteer support groups that we're going to talk about later, our legislative initiatives, our peer-to-peer support, please contact Julie. Oh, and share your story. So we have a lot of programs coming up where you can get involved. So tonight we're going to be meeting with a number of the staff members from the NYU HCM team, and the director, Mark Sharon, is below me right now in this box system we have. So Mark, you want to kick off the meeting and introduce us to your team?
Thank you, Lisa, and thank you for pivoting to virtual so quickly and flawlessly.
I'm not sure if it's been so flawless, but thank you.
We're counting on it. Anyway, I'd like to introduce you first to Dr. Dan Swistel, who's the surgical director of the HCM program. And many of you have met him, and we're grateful to have his brilliance and his technical expertise to help our patients who need surgery. Dr. Daniele Massera has joined the HCM program about 2 years ago and sees patients in parallel with me, and is an accomplished researcher as well. And Maria DeFonte, a nurse practitioner of the HCM, who will be talking with you tonight about lifestyle modifications in HCM, which I know is a subject that many of you are very interested in. So that's our introductions. Shall I get started, Lisa?
Well, I actually go first.
Oh, you go first.
I go first. So you got to pivot it back to me. Then I'm going to hand it back to you guys for the rest of the night.
Great.
I was trying to figure this out this morning, Mark, as I was planning for this meeting. And I even hate bringing it up because it makes me feel old. How long have I known you now?
Too damn long.
23, 24 years?
Oh dear.
Yeah. Yeah.
It seems just like yesterday, Lisa.
A long yesterday. It sounds like a 2020 yesterday. Yeah. So, Mark and I started working together many, many years ago when there were but 5 programs in the United States really focusing on hypertrophic cardiomyopathy, his being one of them. And it's been an amazing journey to see HCM grow, to see his program grow, to see so many patients helped by the program. And I'm just really happy that your institution may have changed since we first met, but your team has grown and the services have just been fantastic. So I'm going to share my slides here and we're going to get going. And I'm going to bring, I'm actually, you know what? You can give me 1 second here. I did a mistake here and I need to switch my screen so that I can look at you while we're talking. My apologies. And then we're going to do a display setting.
So I remember when Lisa first contacted me, and the notion was to educate patients about this condition and also to make sure that patients arrived at centers that knew something about the condition. And it was just around the time that the internet was beginning. And I know you find it hard to believe that we ever lived without the internet, but we did. And she said, well, I'm going to use the internet to reach out to patients because what happens, Mark, she said, was that patients talk to their docs and they suddenly realize in talking to their doctor that, that they maybe have 1 or 2 patients in their practices and that they don't really have a whole lot to offer. So it's my mission to educate patients about the disease so that it's not such a black box, and also to steer patients to doctors who know something about the condition. And as far as I know, that's been the mission ever since, without any interruption in the 23 years that I've known her.
There was a slight interruption for a couple of months, but
oh yes, that's right. I forgot about that. I guess
fix that.
But that was only because you were asleep, Lisa.
You've got a point there, because I actually did work up until the day before transplant and literally from the 48 hours after waking up. So thank you for that intro while my husband closed the door and my computer got back in line. So hi, everybody. For those of you who don't know me, my name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. We started this little adventure in 1996 after the death of my sister, and it has continued to grow throughout the years. And here we are today to present you where we are in 2020 and how you can get involved in helping us build a better future for everybody with HCM. So this is what's going to happen tonight. We're going to talk about a number of issues related to HCM. We're going to look at step management. We're going to look at surgery. We're going to look at sudden death prevention and lifestyle modifications. And at the end of the session, we're going to take your questions and answers. And when I'm done talking, I'm going to put a poll up so you can tell us where you're coming from, because I forgot to do that in the beginning. Someday I'm going to get this all perfect, but it doesn't look like it's today. So we will do Q&A here in the webinar room. If you're watching us on Facebook, use the link, log into the webinar, and you can participate in the Q&A. And then there's kind of an after party. Once we close the webinar, we will then go to a meeting room, and that meeting room will allow you to ask individual questions aloud. Sometimes it's a little easier to ask a question that way than in writing. So those of you who are logged into the Zoom webinar, you will have that opportunity shortly. So HCM. I'm going to do this part really fast because if you're here, you know what HCM is. And if you're a patient with HCM, you've probably experienced some of the things I'm going to talk about here. So the first problem we have in HCM is to decide whether our symptoms are really HCM or something else, but it normally goes the other way around. We're normally first told we have asthma, specifically athletically induced asthma, panic attacks, anxiety attacks, depression, mitral valve prolapse, and innocent murmurs. These are really common themes for those with HCM. And we've recently done a meeting with the FDA. It's called an externally led patient-focused drug development meeting, in which we questioned a great many patients And those patients told us about their diagnostic journeys.
Jesus.
And many of them indicate that these things that were happening years ago when Mark and I started this, concept of teaching people about HCM, the misdiagnoses getting to proper diagnoses remain the same. The percentages are shifting a little bit because we tend to act more on murmurs. But hopefully, as we move forward in technology, we're going to be able to use electronic medical records and tagging to help alert medical professionals that HCM might be something that they want to consider earlier in the process. So how many people have HCM? To me, it seems like everybody does because that's my whole world. But it's not everybody, but it's not as rare as we once thought. We thought it was 1 in 500, and that came from some surveys or some evaluations, I should say, of echocardiograms done in different populations around the world. And it all came out to be about the 0.2%, so like the 1 in 500 number. However, with better imaging, better echo, better genetic testing opportunities, we have found that more than 1 in 500 people have HCM. And we suspect that that number is probably closer to 1 in 200. We don't have a good solid number. However, right now, with these numbers of the 1 in 500 plus, there's over 750,000 people in the United States who have diagnosable HCM right now. Only about 120,000, give or take some, are actually getting care for HCM. And we know that through insurance database statistics. So we obviously have a lot more work to do to raise awareness about HCM, but we also have an obligation to ensure that those with HCM are getting care that is consistent with the highest standards and our best understanding of HCM. So the first thing we have to do is make sure we're all talking about the same disease. And this is becoming more and more important as genetic testing becomes more available to more people. So we know the definition of HCM are these thick walls in the absence of any other structural abnormalities, and they are mostly related to sarcomeric proteins. The sarcomere is the contractile protein or contractile apparatus in the cardiac sarcomere that helps your heart contract and relax. There's over 13 genes with over 3,000 individual mutations that can cause HCM that we know about. There's this other group of people who have HCMs in a clinical fashion. They have all the symptoms. They have the exact same pathway as the people with the known mutations, but we can't find a mutation yet. And then there's these people that act differently, and they are the non-sarcomeric mutations. And this group is probably going to grow. And these people have diseases that have another genetic explanation and can impact other parts of the body or are impacting the hearts in different ways than sarcomeric HCM. So genetic testing can help to find those who have Fabry's disease, Danon disease, AMP kinase, amyloidosis, sarcoidosis. We can figure out who belongs in an HCM center, who belongs in an amyloid center, who belongs with a Fabry specialist. So those people have different pathways to care than the majority of people that we're going to talk about here, although there are some overlaps. So the pathway for HCM is some of you are really lucky and you're very asymptomatic or you're gene positive and don't show the disease yet. You need to follow up throughout life because unfortunately this could change at any time and you could become symptomatic. You could develop a level of phenotype that is identifiable and we might need to take action. That group of people who believe themselves to be asymptomatic and gene positive are a part of this population, but then there's the low risk individuals. So they don't have any risk factors for sudden death. They're not having heart failure symptoms. There's no AFib. Obviously, there's nothing more pronounced, but this is a careful area. Some of these people can fall into a false sense of security because they're asymptomatic. And once we're told that they are low risk, it's really important that you check in with the Center of Excellence often, about every 1 to 3 years, depending upon your situation, to make sure that your risk is still low, because you can be asymptomatic, but still be at high risk for cardiac arrest. And if you walk away with my talk with one little piece, that's the piece I want you to remember, because it's really important. So there's these other pathways for those with HCM, the cardiac arrest risk, which we go to ICD therapy and drug therapy, progressive heart failure. Some of those patients go to myectomy, alcohol ablation, advanced heart failure. There's devices, there's drugs, and then there's transplant. only about 4 to 5% of HCM will go down that particular pathway. And then there's another common pathway, that's atrial fibrillation, which is relatively common, and thankfully stroke, which is relatively uncommon. But these are all pathways that we have to manage with HCM, and this gets complicated. So when you're in your home community and you're not in Manhattan or you're not in a big city and you're going to see a local cardiologist, and even if you are in a big city and you're seeing a small local cardiology practice, the average cardiologist only sees about 10 patients per year, statistically speaking, with HCM. And that's why, to try to figure out these crazy pathways of HCM, who fits in which pathway, if somebody only has 10 patients, it's really hard for them to get a really good grip on what to do for this patient population that can be so diverse. So that's why many years ago, the HCMA created the HCMA Recognized Center of Excellence program, and we began to look for thought leaders in the field of HCM to make sure that these patients were getting care that is proper and within the guidelines and beyond. So we talked earlier today about Dr. Sherrid being one of the original centers of excellence, and today this is even out of date. I can't keep up with myself. There are 41 centers of excellence now. We're about to announce 2 new ones. We delayed their announcement due to COVID, but Houston will be joining the fray, and an expanded program in Orlando has been created. So we have now 41 programs and 8 in the waiting bin till COVID is over. The idea here is that each one of these centers will be a hub and spoke model for their community and their region. So we're hoping that the local cardiologists will refer into the centers of excellence, and those local cardiologists will have an important role in the care of these patients at home, but it's critically important that there's an engagement with the center of excellence. I have Jorge Gonzalez from Scripps here. That was supposed to be a picture of Mark Sharon, so sorry. So what is a center of excellence? Center of excellence has multiple facets, and it's a team. This team approach is critical to the success of the program. There may be different needs for different patients at different times, but the critical component is to come back to the one central person who understands all of the aspects of HCM and knows when to call in their colleagues. So any individual can fly through the filter of imaging, EP, heart failure, and land in a different place at a different part of their HCM journey. And when these patients go to these other places, it's really important that they come back to their what we call hocomologist. HCM is really serious stuff, so you got to allow me 1 or 2 slides to be a little frivolous. So when somebody goes to maternal fetal medicine to have a baby with HCM, they don't stay there, they have to come back. And when somebody goes to surgery or EP, it's really important that they make their way back to their hocomologist so that all of the assessments can be done as this person heads down their HCM journey, which may be very boring for long periods of time, meaning there's no change in symptoms or risk and everything's floating along normally, and you can kind of stay with the hocomologist. But if AFib pops up, you might have a visit with the EP, etc. So this is kind of a sneaky look at something that you're going to hear more about in the coming weeks. The American Heart Association, the American College of Cardiology are going to issue changes to their guidelines document that was originally published in 2011. That document is kind of the roadmap to HCM care. They've decided in the upcoming iteration, and I can't speak much to this, but I can tell you that I gave a talk for the American College of Cardiology, so I was allowed to see pieces of it. It's pretty much under embargo right now. But the concept that the HCMA developed all these years ago has been adopted upward, if you will. So a comprehensive center of excellence is viewed as something that provides every service possibly available for the HCM patient and then some. A primary care program is one that might not have the same high level of advanced imaging or surgery or complex AFib management, but can manage most cases. And then there's the primary cardiologist who has a role, and their roles are indicated by a number of stars. So 5-star is the best, and family screenings can be done in lots of different ways. So you don't always have to go to a center of excellence, but it's really important that you make sure you have a quality echo and that images are really something that can be actionable. So what happens when a patient goes to a center of excellence? We've done surveys on this population for many, many years. we know that they feel that they're more supported and that there's a better quality of life, both physically and emotionally. The outcomes from invasive procedures have lower complication rates than compared with those in community-based settings. And there's an ability to participate in clinical trials and get involved in research. So we know the patients like it. We know that the physicians are doing great jobs at expanding these care models out and just really knocking it out of the park for this patient population. But we also know there's a lot more work to be done because we haven't scratched the tip of the iceberg in the patient population. Kind of went through that already. One other item that is critically important to know about Center of Excellence care is you're less likely to be given therapies that are contraindicated or inappropriate for your HCM. We know HCM can be very complicated in managing hypertension and HCM simultaneously with obstruction. And this can get really tricky, and your local doctor just may not have the expertise for it, with all due, consideration to their abilities. So I'm going to pivot now and talk about some of our support systems that are available. We have a very active social media presence, our one Facebook group. If you have not liked us on Facebook yet, give us some clicks. We're like heading to the next milestone of, I think, 12,000 followers, and actually we're over 12,000 followers. It's 12,000 likes. So join us, check us, like us, follow us. But there is a private group for patients only. Sorry, docs, you're not allowed into this one. So the patient community monitors itself. We have trained moderators, some of which have been working with us for over a decade. They've gone through all their own HCM journeys and are there to help guide the conversation and lead you to good information and good sources and good resources, whether it's figuring out SSDI or maybe you're filing an appeal with your insurance company. Your peers can help you, and then the HCMA office can help you. So you can join us. We're working on a new program. It's going to be slow to development. It's called HCMAI. It's an international outreach effort. And all of the international components will be given a page on the Facebook page, or on the Facebook, they'll be given a group off the Facebook page where the international group can all come together as patients, and we can all hopefully work towards better treatments and cures, and not cures, I use the C word. How did that happen? Better treatments for those with HCM, and hopefully participate in trials. We are about to launch. I thought we were going to do it in September. I'm sorry, we're a little bit late. We'll get it done very soon. We're going to have an online support group system. Eventually we'll go back to the in-person thing too. But for right now, I think this model actually works better for those with HCM. We're too tired to go out at night. So you'll be looking towards getting some notices of groups. Some of them are going to be set up based on age. So we're going to have a teen to 20-year-old group. Some of them are going to be, I'm going to do a once a month with me pre-myectomy talk. I might be tapping people on the shoulder like one of our speakers here and say, hey, come on in and talk to the patients for a minute. But we'll walk you through the myectomy experience in a support group situation, ICDs. We have people that specialize in journaling their emotions, and we have other people who thinking of talking about sports and exercise and activity and coping with family members. We're going to have all different subgroups, so look for them and join us. We're also, once that's up and launched, we're going to start a more formalized peer-to-peer Bighearted Friend system. Many of you know that I've linked you up individually with others who have gone through similar situations. I've got about 15,000 of you in the database now, and it's getting a little hard to figure out who should be talking to who. So we're going to use some technology in our new website that's coming up that's going to help us match you. Think about it like the eHarmony of HCM. You'll each fill out surveys and you'll find a peer. And it may be a short-term relationship, it may be a long-term relationship, and you'll both have support from the HCMA office. We also have our podcast system, which is, we're actually live tomorrow with Marty Marin. We're going to be talking about cardiac imaging. That can be found streamed to Facebook and then up on our Podbean account. So you can get that on iTunes. One of the things we're going to be doing with the Share Your Story and the podcast is a breakout of the podcast. We're going to be videotaping people's experiences with HCM. It's the Share Your Story program. Right now, we're booking out about 25, 30 people to record their HCM experiences, which will all be used on our up and coming website, hopefully first quarter of 2021, where you are going to help guide your peers live to them, recorded to you at whatever time of day they need you and they need information. So if you are interested in sharing a piece of your HCM journey, what your symptoms feel like, what your therapies were like, what your symptoms are like, how it affected you emotionally, the loss of a loved one, whatever you want to tell us. We're going to put this together in an educational format so that you can help others understand that they're not alone in their journey. So look out for that. Oh, by the way, you're going to be getting a survey after this. So there might be a link to sign up to become a volunteer, and you can tell us what you want to volunteer in. So we're going to be doing a legislative advocacy initiative for 2021. We are going to be holding a meeting for anybody who's previously signed up to be a legislative advocate. That meeting's coming up on Monday, and we're going to show you what we've built out and what we're planning. So stay tuned for that one. After we do the launch meeting, we'll do one to the public, probably December, January, once we get everything else in order. And that, oh, if you have not seen the patient-focused drug development meeting, go to our YouTube site. You will see some amazing stories, and you'll get a glimpse of what we're going to be doing with the new website, with some of the way that we've explained some of these stories. COVID made us change things. Not necessarily a bad thing. It made us think about things differently. And this is one of the things we had to rethink for COVID. Oh, no, stop. Okay, I was going to start the video. We didn't want to do that. So please go watch the PFDD. It is 4.5 hours long. You can fast forward through it, but I think you'll get the message. And I think the FDA did too. So I want to thank everybody for their participation tonight, our NYU partners, our Center of Excellence partners around the country, our staff, our board, our volunteers. And for those of you who don't know, my donor's name was Brandy. She was a New York girl. That's all I know about her. So this Jersey girl has a New York heart, and my heart's name is Brandy. So I am going to stop my presentation. I am going to deploy the poll that I was supposed to do before. So while Dr. Sherrid is going to give his talk next, you now have the opportunity to participate in the poll. And after he speaks, we will tell you who you all are, where you're coming in from. So please take the poll now. And without further ado, I am going to hand off to Dr. Mark Sharon.
Thank you, Lisa. So the HCMA has a lot more focuses than when it started. Thank you for that overview. And the legislative part is so important because that's, besides education, that's the way we're going to change things about care. So my disclosures are that I'm a consultant for a South Korean company called Celltrion that's developing a drug for HCM. And also a disclosure that the myosin ATPase inhibitor mavacamten is in clinical trials and it's not yet approved by the US FDA. So HCM, hypertrophic cardiomyopathy, thick heart muscle disease that can involve almost any part of the heart, but most commonly the septum, the part between the right ventricle and the left ventricle. Another sort of HCM that's quite important is apical Hcm. Here, just involving the apex, the heart's upside down here, just involving the apex. A little foci here of thickening just below the aortic valve, subaortic thickening. Here, mid-ventricular thickening in the middle of the ventricle. And in this case, it's shown that it's causing obstruction in the mid-LV, which leads in this particular situation to this patient to an aneurysm at the LV apex, which has important prognostic significance. So, you know, it turns out that HCM is actually more common than we thought. If you define HCM as unexplained thickening, I think one of the reasons why we and other centers have been so busy is that it's not a 0.2% disease. That was what we thought with echocardiography. But if you actually take normals and you exclude all the people with hypertension, morbid obesity, valve calcification, all the known causes of hypertension, of hypertrophy, and then you do CMR on them or MRIs, that the actual prevalence of unexplained LV hypertrophy is 1.4% in a middle-aged population. 1.4%, that's a very common condition. So 67 of 4,900 patients had two adjacent CMR segments greater than or equal to 15 millimeters thickness. So, you know, this paper published by my colleague Massera, it can be read in the Journal of the American Heart Association. And I think that not all these patients know they have HCM, clearly, and not all these patients may have symptoms. Not all these patients may come to medical attention. But unexplained thickening is actually more common than we thought with echocardiography. You'll see more of this later. This is the ultrastructure of muscle, showing the myocyte disarray, the tangled, disorganized muscle cells as opposed to lining up in a nice orderly fashion. These are like a traffic jam in Manhattan. And there's fibrosis, this stained red here, causing toughness, stiffness, impaired relaxation of the heart, which is one of the physiologic hallmarks of HCM. The heart can't relax, as well as narrowing of the small vessels of the heart, intramural or in the muscle narrowings of the coronary arteries. You'll hear that HCM is often associated with a pathologic variant in 40% of patients that we test. And these are the molecular motors of the heart that cause the heart to contract. And my colleague, Maria DeFonte, will be talking a little bit more about this later on. These patients' disease can be tracked through their families if we find a variant. But we have to explain to patients that if we don't find a variant, it doesn't mean that they don't have HCM. It just means that science hasn't caught up with them yet. We haven't discovered all the variants yet. So what about obstruction? The great dichotomy in HCM is between patients who have obstruction, which is most commonly caused by the mitral valve being pushed into the wall of the heart as the heart contracts. Long mitral valve leaflets here shown touching the septum and blocking the blood as it gets out, to patients where the mitral valve stays in the center, and these patients have non-obstructive HCM. So what do we try to talk about with the patients? So there are 5 aspects of HCM treatment that come up, and we try to handle this over a course of 2 visits. First of all, we try to figure out who might be at risk for dying suddenly. And Dr. Massera will be talking later on about the risk stratification paradigms that we have to try to figure out who might die suddenly, which is clearly the most tragic and the worst complication of HCM. Because these are the patients who are at high risk that we want to place an ICD. Often patients will come because of symptoms, and this is a big focus in more than half the patients. We advise patients to avoid competitive athletics and extremes of strenuous exertion. So this wording is very carefully chosen to allow and encourage exercise, in particular exercise that is repetitive and aerobic and allows patients to keep their muscles in trim and to avoid obesity. But we do advise patients not to compete because there seems to be something about pushing yourself in competition, about getting around the defender with the ball, about stretching a single into a triple that is associated with dying suddenly. We test first-degree relatives to see if they've inherited the condition with the traditional paradigm of echo EKG or the newer genotype paradigm by doing a genotype, a blood test, or a mouth scraping. And we don't want patients to get 2 heart diseases, right? So, you know, the disease that all your neighbors get is coronary disease. People talk about a heart attack. Well, that's a coronary occlusion caused by narrowing of the blood vessels and coronary artery disease. So we detect and treat hyperlipidemia fairly aggressively to avoid patients getting two diseases, because if they get coronary disease on top of HCM, there's an adverse synergy. And for many patients, about 25% of patients get atrial fibrillation, and we'll be discussing with them atrial fibrillation, rate control, rhythm control, marked obesity, because that has an adverse effect on the HCM phenotype. We'll talk with them about diet, and for the most overweight, we'll talk about bariatric surgery. And we always remember that this is a chronic illness, and dealing with chronic illness requires a lot of counseling, often a lot of time, and a lot of emotional support to come to grips with the disease, deal with it in an appropriate way. So what about risk stratification? Dr. Massera will be talking about this, but it comes first. We try to figure out if patients are high risk or low risk for dying. About 15% of patients, 20% of patients are at high risk, and those are the patients who we recommend getting an ICD, as opposed to the patients who are at low risk, who we just move right on to treatment of symptoms, which is mainly what I'm going to talk about. Let me talk first about non-obstructive HCM, because I often don't get to that in these talks, and it's a very good idea to put it first then. So about a third of the patients don't have obstruction either at rest or with provocation. It's due to a small left ventricle, diastolic dysfunction, which means a stiff heart, and a stroke volume which does not increase after exercise. So normally the heart can increase its pumping function by a factor of 4 to 5 times with exercise, but in HCM, we'd be lucky if we got 2 or 3 times increase in the amount of blood that's pumped by the heart. And in non-obstructive HCM, this happens because the heart can't expand because it's so stiff. Because it's hard to find good treatments for non-obstructive HCM, we make every effort to diagnose obstruction, including provocation with stress exercise echo, or a newer test, which is exercising patients after eating, because many patients who have obstruction will say that they feel worse after eating and then trying to exercise. And so we have the ability now to exercise patients after eating, and we've even added an order in our echocardiography order set, the postprandial stress echo, and you can be sure that when an order actually gets incorporated into the computerized medical record, that it's a real thing. So for non-obstructive HCM, we'll give empiric trials of verapamil or beta blockade, which can work in some patients. And diuretics are often helpful in patients who have pulmonary congestion, fluid retention, and edema. The new drug, which is not yet approved, mavacamten, is being studied in non-obstructive HCM as well as obstructive HCM. And finally, if medications fail and the patients are wretched, we have a surgical treatment now for non-obstructive HCM, which is to increase this small LV volume that I mentioned to you earlier by doing a very extended myectomy, done only really at centers that have a lot of experience with surgery. And in these patients, there can be a dramatic improvement in their symptomatic status by increasing the size of their left ventricles. Now, we all also, I think, know that such patients can have heart transplantation as well. At our center, we'll generally, for most patients with this, advise the extended myectomy, both from the aorta and through the apex, to try to improve the size of the left ventricle before recommending heart transplantation. I think that might be somewhat controversial. However, heart transplantation has its own problems, including the need for medicines that have a certain amount of toxicity. as well as a certain risk to the whole procedure. And our view is, and with our experience, we've seen that many patients will get better if we can increase the size of their tiniest LVs. But now moving on to obstruction. This is what it looks like on the echocardiogram. Here, a thick septum, and here the valve being pushed into the wall of the heart. Here's another view. And you know, those of you who know something about this realize that sometimes the mitral valve is very elongated as well. And this happens, I think, in the majority of patients that have abnormalities of their mitral valve, as well as thickening, and this contributes to obstruction. We've taken to calling this the nightcap mitral valve because of its floppiness and because of its length. And here's what we understand now causes this anterior motion of the mitral valve, that the flow here, shown with color Doppler, gets on the wrong side of the mitral valve and pushes it into the wall of the heart, causing this obstruction. And it's completely analogous to the wind getting behind a spinnaker of this sailboat. Here's a 3D echo. Here is that mitral valve being pushed into the septum. We're kind of looking from the ventricle, looking up at the outflow tract, and you can see this tongue of the mitral valve. And this will figure in a later talk because that tongue there that sticks into the outflow tract can be addressed now surgically. That's a stop frame of it right here. And so the flow has to go on either side of the orifice, and it's no surprise that this causes substantial symptoms. So one of the characteristics of obstruction is that it is labile. It can go up and down and worsen. And one of the things that you probably have been asked to do is to push down against a closed throat, the Valsalva maneuver. But standing also brings out obstruction. This is the Doppler echocardiogram showing a greatly increased velocity of blood after standing. And so we do this on every patient. And in about 30% of patients, the standing gradient is actually higher than the Valsalva gradient. And so this is part of our standard echocardiogram. And exercise is better than either at bringing out gradients. Also, I mentioned eating. These are the resting echoes. And suffice it to say, these are normal velocities, but we were reasonably sure this patient actually did obstruct. And so we fed the patient and then had them exercise, and there was this enormous rise in the pressure difference after eating. So there's rarely urgency in the treatment of obstruction. Though the symptoms may be severe, there's plenty of time to think. Moreover, there's plenty of time to get an expert opinion. Don't have to rush into treatment. There are medicines which definitely worsen obstruction. Most patients get better with medicines, and in Latin, do no harm. That's the first rule. Of all patients with HCM, pharmacologic therapy takes care of most patients, and only, I'd say about a quarter need to have invasive therapy. So what are the medicines that worsen obstruction? Well, there are a lot of medicines that make patients worse. And I would say that 40% of the patients come to us are on the wrong meds, because these are medicines that they're used for other heart conditions, like nitrates, the ARBs, the ACE inhibitors for hypertension or renal disease, nifedipine or amlodipine for blood pressure. The prostate medicines and in SINs are big offenders. In the hospital, dopamine or dobutamine will make patients very sick. Digoxin makes people sick, and any attention deficit disorder drug that has amphetamine-like capability is contraindicated in patients with HCM. So the HCM world is very much like walking through the looking glass. We have to discard many of the drugs that we use in poor pump function and in angina from coronary disease, and discard those drugs and use specific HCM drugs. And so how should we treat symptoms in obstructive HCM patients who don't respond to the first line therapy, usually beta blocker or verapamil. So these are obstructed folks who get a beta blocker, but they're still feeling poorly. And so here's what we have in 2020. We have disopyramide, which is a drug that helps about 60% of patients. We have new trials of myosin ATPase inhibitors, of which there are 2. We have in Japan and France the drug cybenzaline, and a trial is being started with an alteration of the molecule of cybenzaline. There's surgical septal myectomy, alcohol septal ablation, and in frail elderly patients, pacing of the ventricle by changing the depolarization pattern of the left ventricle and instituting a short AV delay in the pacemaker, programming it in a specific way. We can help patients who are too frail to have anything else. So in this algorithm, patients with symptoms are usually given beta blocker. Disopyramide is added, but I will add that it is added really only in specific centers who have experience with its use. The big ones in the US are our center, in Canada and Toronto. There is expanding use of this drug around the country as patients report good results and as physicians are getting more and more familiar with it. I'll tell you a little bit more about disopyramide as time goes on, certainly used in London a lot. Patients who fail disopyramide get mechanical therapy, which is usually septal myectomy. At our institution, it's about 20 myectomies to 1 ablation. So disopyramide's an antiarrhythmic drug, but it has strong negative inotropic effects. It decreases gradients and helps symptoms in about 2/3 of patients. Usual maintenance dose is about 500 milligrams a day. And at this point, we're prescribing the regular release preparation. By ACC/AHA guidelines, it's recommended with a 2A recommendation in 2011, and it has a class 1 recommendation from the ESC, European Society, in 2014. It's stronger than either verapamil or propranolol. In the same patients, disopyramide lowers the pressure gradient or the pressure difference across the LV tract by about 60% compared to propranolol, which is a beta blocker, or verapamil of -8%. So stronger drug works better, but it has its limitations. Mainly, it causes the side effects of dry mouth and exacerbation of prostatitism. So we never started in anyone who has prostatitism, who has difficulty voiding. And the dry mouth can be mitigated by a cholinesterase inhibitor, another medication, for patients who complain about dry mouth. And I would say about 30% of the patients wind up taking that medication along with the disopyramide because they don't like having a dry mouth. But it works. This is given in the cath lab, the cardiac cath lab, with a resolution of the pressure difference. In the echo lab, resolution of the echo gradients, and then after the drug is washed out, the gradient comes back. And when we looked at this in 2012, about 40% of the patients of our total population needed some kind of advanced care because they had failed beta blocker or because they were excluding the non-obstructed patients, who were 40% of the patients, the whole population. It was 299 patients at that time. And we wrote up our experience about this. Suffice it to say that of the 300 patients in this particular study, we usually started disopyramide, but there were patients who were operated on primarily before a trial of disopyramide. This depended on what the ventricle looked like and what the mitral valve looked like, and also whether the patients had problems beforehand that would prevent the disopyramide use, like a very markedly abnormal cardiogram with a long QT segment beforehand. There were patients who had good success, and the 141 patients got diso as long-term therapy. So you could get surgery here if you failed disopyramide, and there were patients who were operated on primarily before giving a trial of disopyramide. And, the gradients came down. There was a reduction in the gradients in all the patients, but there were patients who had an inadequate reduction in the gradient, and those patients went on to have surgery. So there's no doubt that surgery is the best way to relieve obstruction in HCM patients. What was important was that these patients had a good prognosis when treated with this overall paradigm of what we called stepped care, where you try medicine, see if it fails, and then go on to surgery if the medicine doesn't work. And so there was no difference in the patients treated with this paradigm of stepped care compared to the expected life expectancy of a normal age and sex matched group of Americans. So this low mortality went a long way towards its class 1 recommendation. Sudden death risk was vanishingly low. And it can be started in outpatients. In this study from Toronto, there were no cardiac events within 3 months of starting diso in a large number of patients. So what's new? For pharmacologic therapy, there is a drug which has been designed specifically for HCM, mavacamten, which is being evaluated for FDA approval. The exciting thing about this medication is that the gradients come down over time to very low levels as compared to placebo. There were some patients who had some side effects because there is no such thing as free lunch in the world. That's especially true in HCM. But this is encouraging, and it looks like we're hopeful that there will be a new medication for obstructive HCM patients come the end of 2021. So maybe, perhaps, there'll be a new algorithm where we'll add mavacamten instead of disopyramide, or maybe patients will be tried on disopyramide and instead and get mavacamten if they fail. Another possibility is that the drug sibenzolene might be have success in its clinical trials. What's exciting is that really for the first time in 25 years, there are new trials happening for HCM patients. And this is terrific. When you consider that this disease has been around since the beginning of time, that really in 2020, we have clinical trials of targeted therapy of drugs for the very first time that are targeted just for this disease. So what about patients who fail medications? Because there are people who just can't make it up the stairs. And, the myectomy in the beginning had a checkered history. And that was because the physicians who did the myectomy were just taking out the muscle here in the proximal septum and not extending the myectomy down towards further down into the ventricle. So the extended myectomy redirects the flow away from the mitral valve so it doesn't catch it, and also the resection allows the papillary muscles to drop down, also separating the inflow from the outflow portions of the left ventricle. In addition, my colleague, Dr. Dan Swistel, who you hear next, pioneered this wonderful procedure called the RELEX, or the Residual Leaflet Excision. Here, that tongue, that protruding portion of the residual leaflet is attacked directly by resecting it. Clearly, you don't want to take too much, you don't want to take too little, and you have to make sure that the leaflet is supported. This can only be done by a surgeon with a lot of experience, but it has helped our patients immensely in the 550 patients or so that he's operated on. So here's an example of a patient who, let's see if I can show that again. Here's a patient with obstruction, with this very thick heart and the mitral valve hitting the septum. Here's the aortic valve, and here's the mitral valve touching the septum. This patient had a shortening of the mitral valve and a resection of the septum, both at the same setting. And I'm just showing you this picture to set you up for the next talk, but this patient is going to do very well after their myectomy. There's no longer SAM, the mitral valve is nice and short, and this patient will be able to exercise normally. So pharmacologic therapy for patients with obstructive HCM is often effective at reducing gradient and alleviating symptoms. Want to discontinue medicines that make the obstruction worse. Pressure gradients and their symptoms can be improved with beta blockade, better with stronger negative inotropes like disopyramide. And the future is bright for testing pharmacologic agents that will improve LV outflow tract obstruction and even diastolic dysfunction. So I'll leave you with a poem, a very brief poem that I think symbolizes our whole wish list here, from Gary Snyder, my favorite American poet. After weeks of watching the roof leak, I fixed it tonight by moving a single board. So thanks for your attention.
Thank you,
I
Mark.
think that we're ready for the next talk.
Okay, so I'm going to take it back for just a minute while you stop your screen share and Dan starts his screen share. I'm going to encourage everybody who has not participated in the poll yet to please do so now, because we're going to close the poll and we would like to know where you're coming from and a little bit about your HCM experience, so we can take that into context when we do the Q&A. I was remiss on one of my slides earlier. While it was on the slide, I did not give the appropriate call out to our sponsors of this program, which include MyoKardia, Cytokinetics, Boston Scientific, and Invitae. So we thank them very much for their financial support of this meeting tour, and we look forward to working with them in the coming years, even if some of them might change their name to Bristol Myers Squibb. We'll find friends there too, I'm sure. Okay, so if a couple more of you could do the poll, I'm going to leave it open while Dr. Swistel gives his talk. And without further ado, I hand the podium over to Dr. Daniel Swistel, who will talk about myectomy and all of the intricate ways that he has found to improve this surgery over the years.
Thank you, Lisa. Thank you very much, and thanks for running this program. I know that from all the patients I've spoken to over all these years, they've found the HCMA an invaluable resource for themselves, and I congratulate you for running this program and all the years that you've invested in advocacy for HCM. So I am Dan Swistel. I am the surgical director of the hypertrophic cardiomyopathy program at NYU. And a lot of things that one would want to know about surgery, Dr. Sherrid nicely touched upon. So we'll see if we can expand a little bit on some of those thoughts. Sort of my favorite pictures, you can imagine slicing the human heart in half and looking at the interior chambers, you would see the marked hypertrophy of the muscle here on the left-hand side. And if you follow the white line, this is the way the blood comes from the lungs and enters the left ventricular, the main pumping chamber. And then what it really wants to do is follow the black line and get out the aortic valve in this direction. But as you can see from this very clever drawing, that it's having a lot of trouble getting out because there's just no room here. And a lot of it ends up leaking backwards through the mitral valve and back into the chamber that is draining blood from the lungs. So that's sort of a, by and large, difficult scenario, and it just can't go on. There are indications that we use for surgery. Dr. Sherrid touched on some of these things, but it's fairly simple, some of these indications. Mostly, you have to have some sort of a symptom. You have to be short of breath, or you have to have chest pain. You have to be complaining of something. And when we do diagnostic tests, we have to be able to show that there is a pressure gradient between the inside of your heart and the distal circulation of your heart. And in general, that pressure gradient has to be at least 50 millimeters of mercury. But that can be either on provocation, like a stress echo, or at rest, doesn't matter. And of course, lastly, you have to have something wrong that the surgeon who knows what he or she is doing thinks that they can fix. So it has to be some sort of what we call morphology that is reparable by an experienced operator. There are some relative indications for surgery. We'd like that younger patients get sent to surgery sooner rather than later. They have their whole lives ahead of them, so they might as well get this fixed by surgery, which still does remain the gold standard for caring for obstructive hypertrophic cardiomyopathy. We've also learned from experience that patients that have a version of obstruction that more involves complicated subvalvular structures. There are structures inside of the left ventricle which are necessary to operate the valves. And if those structures are more abnormal than the simple hypertrophy, those patients tend to do better with surgery as well. Of course, if there's something else wrong with your heart unrelated to HCM, like coronary disease or aortic valve disease, then yeah, you should have surgery because those things cannot be addressed with conventional pharmacologic therapy for HCM. We still feel that this surgery should be done in an experienced center. This operation, although relatively short compared to many heart surgeries, is relatively tricky. And we feel that you really do need some significant degree of experience in order to do the best that's possible to be done in this day and age for patients with obstruction. Surgery is actually, for HCM, is one of the oldest operations that were performed once the technology of heart-lung bypass machinery was perfected back in the mid-1950s. And this has given us a lot of time and a long experience in trying to develop really the best kind of procedure. So these procedures have evolved greatly since this operation was first done in the mid-1950s, and we'll talk about that just ever so briefly. Interestingly, as Lisa and both Lisa and Dr. Sherrid pointed out, with improved diagnostics and improved echocardiography, we have discovered that there are lots of different versions of obstruction for hypertrophic cardiomyopathy, some of which don't even have hypertrophy of the muscle at all, which leads one to think that we should really call this left ventricular outflow tract disease more so than obstructive hypertrophic cardiomyopathy. And frankly, back in the 1980s, as you see the quote at the bottom, Dr. Mann, who's working in Boston at this time, he and Dr. McIntosh, one of the earlier surgeons for HCM, were quoted as saying that, in fact, even in the 1980s, it's relatively rare to see a patient who just has simple, asymmetric hypertrophy. There's always, or more often than not, something else going on that needs to be dealt with. So we have a whole laundry list of things that we need to measure, which is another reason why centers of excellence become so important in the management of HCM, because we want to look at not just hypertrophy of the septum, but a whole laundry list of different abnormalities that may be contributing to obstruction. And I don't think I need to go through this whole list one by one, but as you see, It's a laundry list of abnormalities that we study in each and every patient who may need to have surgical septal reduction therapy. The simplest of these, Dr. Sherrid spoke about, this was developed back in the 1980s, is simply to take out more muscle. Early in the 1950s, taking out muscle was done relatively blindly, but now with our technologies and better diagnostic equipment, we can tailor the size of the resected muscle to each individual patient. This allows us to do what's called a so-called extended myectomy, where we can tailor the amount of muscle removed to where the muscle is located and how thick it is at that particular location. But going back to the more complicated issues, this diagram nicely shows that obstruction is an interaction of a variety of factors. Structural abnormalities that I briefly touched upon, geometric factors that we often can't do so much about, and also kinetic factors, or the dynamic contractility of the muscle itself. And all of these things work together and conspire to give you symptoms, cause obstruction, and things that can be treated either pharmacologically or surgically, depending on each individual situation. The fact of the matter is that you can have obstruction without any thickening of the heart muscle at all, as I've been sort of talking on. One of my major talking points today, in fact, is to address this exact situation. Well, what are you going to do with all of these other factors? And can we look at these other factors, and after we study them, have we devised a laundry list of ways to fix it? So back in the early 2020, well, in the beginning of this century, I guess that would be like almost 20 years ago now, knowing all of this information, I devised a logarithm, or let's call it a roadmap, where you can analyze the pathophysiology or the morphology, what's wrong, in other words, and then devise a system of stepwise system of surgically addressing each of these different aspects. And we call this the RPR procedure, or the RPR roadmap, resection, plication, release. And again, this is just that laundry list that I was talking about earlier of different things that we've developed over time that we can use in any combination in order to get the absolute best result. The best result is one where, when we're finished, there's no obstruction between the left ventricle chamber and its distal circulation. And also there's no leakage of the mitral valve, causing that murmur that Lisa mentioned at the beginning of her talk as well. So all of these different procedures exist, and we can use any of them in combination, or all of them, or none of them, depending on what is necessary for that particular case. So it's important to understand that each patient is different, and each patient needs a specially tailored procedure in order to get the best absolute result. And just a couple diagrams. I developed this procedure a number of years ago. This is just shortening of the mitral valve that Dr. Sherrid spoke briefly about. You can look at the mitral valve from inside the aorta, which is the access point for doing this operation. A friend of mine who runs an HCM surgical center outside of Milan has popularized judiciously removing some of the attachments to the mitral valve, which are getting in the way, that are abnormally short or abnormally located. And with experience, some of these can be judiciously removed. And as you see from those diagrams, the mitral valve can then go back to the location where it's meant to be in the first place. This is a drawing from my colleagues at the Mayo Clinic. They just have a very nice drawing showing that sometimes there are incredible extra muscles altogether inside of the heart, and these extra muscles get in the way. And again, with careful assessment, they can often be judiciously removed and develop a more normal morphology and structural anatomy inside the heart. And this is an example of one that I removed from one of our patients some time ago. And you can see those little strings that attach to the mitral valve and the muscle that it's attached to. And there are so many of these in many patients that some of them can be removed under careful assessment. Dr. Sherrid showed you this picture. This is another one of those technologies that I helped develop where the leading edge of the mitral valve can be removed. And hopefully we can assess this with sophisticated three-dimensional echocardiography. And I think I have a better picture of that coming up. So just briefly, we've operated on over 500 patients. And as you see from the point of my talk, that less than half of these patients just have regular muscle resections. Well, more than half of them actually have to have some other procedure related to the relief of obstruction. They all have symptoms. They're all in what's called New York Heart Association class 3 or above. They all have very high pressure gradients, some as high as 230 millimeters that you see here in this number here. Their septums can be of varying thickness, and a lot of them have leakage of their mitral valve. And of course, because these patients come in all different age groups, they can develop a lot of other abnormalities like diabetes, obstructive pulmonary disease. Some patients have high cholesterols, et cetera, et cetera. And these all have to be studied. Despite that, the complication rate from surgery is extremely low. This operation is highly and well tolerated by the overwhelming majority of patients. The complication rate is less than 1%. It's only about 0.5%. And the need for a permanent pacemaker, which is a more common situation after surgery, is as low as 2.8%. We did take a group of patients and we followed them years ago to see what would happen to them in as long as a 10-year period of time, you see here. And you see their gradients remain, after 10 years, extremely low. Their heart function remains normal. Their septums approach a normal morphology, and they have, by and large, no mitral insufficiency. It's an extremely successful operation if done under the right circumstances in the right experienced center. Near the end, I want to just show this graphic slides that were written up by Dr. Barry Mann, who I said earlier is now in Boston. And it's important to understand that patients that have surgical myectomy, their life prognosis here at 10 years is very, very close, if not statistically not different from that of the expected population. So if you took a group of patients with obstruction and surgery and compared them to a group of matched patients who don't have obstruction or surgery, who just don't have HCM, their life prognosis is more or less parallel. On the right-hand side, you can see that if you had a group of patients, and Dr. Mann was lucky enough for a variety of reasons to have a group of patients who had obstruction but did not have surgery for whatever reason. That's a little more complicated scenario, but look at the difference in expected survival after 10 years in patients who have surgical myectomy compared to those patients who have obstruction without surgery. And again, if you take away all the patients who succumbed for other reasons, and like being struck by lightning, for instance, and just studied their HCM-related complications, again, patients with surgical myectomy do wildly better than obstructed patients who don't have surgery. And furthermore, and lastly, the incidence of sudden death is thought, and this is still controversial, the incidence of sudden death in patients after surgical myectomy is by and large the same as that as the general population. And although this is controversial, and we would still be recommending placement of ICDs in patients who are at high risk for sudden death with or without surgical myectomy, this is an indication that it's possible that the risk of sudden death could be dramatically affected by successful surgical myectomy. So in conclusion, let me just say that surgical myectomy remains extremely safe and effective and long-lasting, as I've shown. It dramatically restores the level of activity. There's usually no shortness of breath or chest pain. And when accomplished at an experienced center, the life prognosis parallels that of the general population. And again, very careful to say that this is controversial. It may lower the incidence of sudden death in a susceptible subset of patients. So I'll just take a couple of minutes. I'm not going to show you these echoes because Dr. Sharon already showed you some, but I'd like to think of this video, because if you imagine you're a character in that movie Fantastic Voyage, and I'm nervous that I'm dating myself a little bit, and you're sitting in a little submarine at the apex of the left ventricle, and you need to get out, and you can't get out because the yellow arrow is pointing to your way out, but there's nowhere to go. But after surgical myectomy, and you make a little pathway, and you trim the mitral valve a little bit, now your submarine gets out through the top there, and you can even see the aortic valve as your escape route underneath the yellow arrow. Lastly, Lisa thought you might be interested in looking at a myectomy, so I'm just going to run this video ever so briefly. It's a little graphic, so you might want to turn away if you're not into cutting. But this is a picture of the heart. I've done away with all the previous work that's necessary to get here, but we're looking inside the left ventricle through the aortic valve in this particular view. And I'll just run this video. And that little white line that you see here is where the mitral valve is banging into the ventricle. And it causes an actual callus that you can see. So I'm going to use this hook in order to get a little counter traction. Here comes the knife. I'm going to make that little pathway that you saw in that three-dimensional echocardiogram. I can stop this, Lisa, if we're going overboard. I know we're a little
Everybody
over.
always likes these videos. And
yeah, we're a little over time.
Nah.
You see, there's a lot of blood underneath my field here, which is really annoying, but I'm trying not to move my head. This is really good. Watch this. I'm going to adjust my vent cannulas without moving my head. Oh, there goes the suction. So, this is much better now. Now I can see what I'm doing. Let's move on.
So Dan, while we're watching this, and Mark, I'm going to ask you to unmute yourself for this conversation as well. I've been thinking a lot lately of the nearly 25-year history of the HCMA and how many different attempts there have been to deal with this problem of obstruction. When I first came on the scene, I got a dual chamber pacer defib because that was going to fix, or no, I'm sorry, dual chamber pacer, no defib, because dual chamber pacing was going to solve the problem because surgery was not very widely available. So pacing was. Then alcohol ablation came on the scene and tried to say, we don't need to do surgery, we can do alcohol ablation. And now we're looking at medications that might eradicate the need for surgery in some people's view.
That will never happen.
But I think the reality is we have more tools in our toolbox now. And how critical
very
it is
well said.
To see how many different ways we can address the problem, but we need to do this. So, you know, the evolution in my mind has always showed that whatever's new is going to be the thing, but we're just going to have more tools. Mark, what do you think?
I think there's always going to be patients who fail medications because the anatomy is just so adverse. I think that it's worth trying medications. I think that in a lot of patients, there'll be responses, and some of the responses will be quite long lasting. But for patients with really long mitral valves or really displaced mitral valves, where the valve is sitting right in the middle of the flow, they're still going to have obstruction, especially after they exercise. And so I'm not completely discouraged. I'm not being, I'm trying to be realistic. I think that the way these medicines work is by decreasing the ejection acceleration, by decreasing the pushing force on the valve. And we've studied that a lot. So decreasing the pushing force on the valve is the way the medications work. But there's some patients that, even with the gentlest breeze, are going to be obstructed.
Absolutely. Okay.
Let me just
picture. Yeah.
Let me just say one thing about those graphs that I showed at the very end, because it makes it seem like patients should all have surgery and should not have medicines. But you'd have to know a little bit more about that group of patients that didn't have surgery for whatever reason, and the comparison between those two groups is a little complicated. I think that what Dr. Sherrid is saying is that his method, or our method of stepwise therapy with the trial of medicines, is a perfectly valid methodology and is very effective in an overwhelming majority of patients. And so I think that's a little different than trying to make a statement about, obstructed patients who are not getting surgical management and what happens to them versus what happens to patients who have so-called stepwise therapy that Dr. Sherrid was describing earlier on.
How much muscle did you take out of this heart approximately? Size or weight?
I don't weigh it, Lisa, so.
Okay.
But
2.5 centimeters?
It's about 4 centimeters long and it's about 1 centimeter thick. But if you want to bear with me for just another couple minutes,
sure.
I'll show this particular patient had not only that muscle resection, but then did have a manipulation of the mitral valve. And perhaps I can fast forward this a little bit beyond. Here, I'm just gilding the lily. We'll fast forward past this section.
How long does it take you to do a myectomy?
These operations, here's where we're going to manipulate the mitral valve. So now that you have a much better view because the muscle's been removed, now you can really see inside the heart. And here's the mitral valve, and here's that tongue that Dr. Sherrid was talking about, and all those attachments that are holding and you can see how that tongue is like sticking up in your way. And it's not hard to imagine how that is being pushed and constantly pushed with every heartbeat into the outflow tract. And the attachments here are so loose that they're useless in terms of functional support for that valve. So I'm going to remove it. Again, this does take a lot of experience because cutting these attachments in an inappropriate way can make the valve permanently dysfunctional, and then the only fallback for that would be a mitral valve replacement. So we're very much interested in preserving the native mitral valve in this day and age. So this is quite a judicious manipulation of the mitral valve. To answer your other question, Lisa, compared to most heart surgeries, this operation is actually quite short. It only takes probably several minutes to do a surgical myectomy. It takes, quite a while to get to this part of the operation. But if an average heart surgery like an aortic valve replacement or a coronary bypass were to be 4 or 5 hours long, this operation is probably only about 2 or 2.5 hours long.
Interesting. Seems like forever to the family that's waiting, and it seems like
yes. Well, it takes a long time to be put to sleep. There's a lot of monitoring that takes place. So all of that takes a lot of time. So it does seem like this operation takes 4 or 5 hours long, but the actual, start to finish surgical part of it is probably only about 2.5 or 3 hours long. So it's relatively short compared to other heart surgeries, but you're right. Yeah, for the family waiting outside in the waiting room, it could be a very long wait. It seems like a very long wait.
Fantastic.
And yeah, there's the little piece, and it looks something like that when we're done. I think that's it.
Fantastic.
Thank you very much.
And next up, who do we have? We have Daniele, who is going to talk about sudden cardiac arrest prevention. I have to go back and look at my notes. So Daniele is the newest member of the team, and he has an accent that doesn't sound like it comes out of New York, which you will soon hear. So you can do your screen share. I'm going to end the poll. I guess some of you had a hard time finding the poll. Sorry about that. So I'm going to share the results of the poll. Most of us are from the Northeast. We only had about half of you taking the poll. So some from the Southeast, Southwest, Midwest, Western United States, and it says Australia, but I'm going to put money on it that it's New Zealand again, because I think you're back. So we've crossed the globe. We've crossed, I think, probably into tomorrow. And we're happy to have everybody here. What is your relationship to HCM? They're mostly patients. There are some who are patients and have family members as well. There's a medical provider joining us today. So we have a few of them have been diagnosed in the last 2 years. Most everybody's on meds. We have 37% with ICDs. Some of them have had that lovely alcohol septal ablation or myectomy that you just heard about. 27% have AFib. 17% have lost a family member. 60% have had genetic testing. And somebody's been advised to get an ICD but hasn't done it yet. And somebody's been advised to have septal reduction therapy, or a few of them, but haven't done it yet. So we have a mixed bag of experienced patients, new patients, all in different parts of their HCM journey. So I hope the person who is considering an ICD might learn something from this next talk. And without further ado, I am going to stop sharing the results and I'm going to hand it over.
Okay, what a video. Thank you, Lisa, and thank you, Mark, for inviting me to participate today. And to the entire team of the HCMA for organizing this event. In the next 20 minutes, I'm going to tackle the other big topic in HCM after symptoms and treating obstruction, and that's the prevention of sudden cardiac death. I do not have any disclosures, and here are my objectives. So first, I'm briefly going to talk about how common HCM is in the context of sudden death. And then I'll give a historical overview over how we got to today, review the causes and etiology of sudden death, and lastly, discuss how we try to decide who is at high risk, who's at low risk, and who should receive a defibrillator, a device that can abort and resuscitate sudden death events. Now, we heard about the prevalence of HCM earlier. This condition affects at least 1 in 500 people, probably more, across all ethnicities and most countries that we know of. According to some estimates, there may be up to 20 million people affected worldwide, but probably only about 10% of these might be clinically identified, which leaves a lot of people potentially exposed to this risk of sudden death. Sudden death is a tragedy. Hank Gathers was a college basketball star who died suddenly at the age of 23 while playing on the court, one of the many victims of HCM. He was known to have ventricular tachycardia, a potentially deadly heart rhythm, and still was continued to play. We estimate that at least a third and up to half of young sudden death victims among competitive athletes are caused by HCM, and most of these tragedies are preventable. So the field has come a really long way since the first description of HCM cohorts in the 1970s. At first, the risk of HCM-related mortality was estimated to be about 6% per year, very high. Now we live in an era of ICDs, heart surgery, like we just saw, transplantation, better resuscitation, better treatment of out-of-hospital cardiac arrest. And more contemporary figures place HCM-related mortality around 0.5% per year, according to some estimates, even lower than the overall US population. So how did we get here? When Donald Tier, a British pathologist, first described HCM, by the way, a very, very spot-on description, he published 8 cases of patients who had the most extreme form of HCM. It was an autopsy series of victims of sudden death. And he described really really a contemporary picture of HCM. Here you see asymmetric septal hypertrophy, the thickening of part of the heart muscle wall. And the histology describes or shows the disorganized muscle architecture like you've previously seen. We owe a lot to this man. This is Michel Mirowski. He was a Polish Jew who was born in the 20s, survived the Holocaust in hiding, and then finally settled in Israel after an odyssey across the world and became a cardiologist. His boss, a distinguished professor of cardiology, had fainting episodes from ventricular tachycardia, and he died suddenly. So Michel Mirowski was haunted by this experience, and he really set out to stubbornly pursue this idea of implanting a human with a defibrillator. And he developed and pioneered it at Johns Hopkins and in Baltimore. So this is the original description in the New England Journal of Medicine from 1980. The history of the ICD and HCM wasn't always a straight line, but this landmark study published in the year 2007 firmly established the role of the ICD in the HCM community. In fact, this graph shows that if you've got an ICD for secondary prevention, meaning that if you already survived a cardiac arrest, after 5 years, you had about a 35% chance of receiving a life-saving ICD shock. And if you got one for primary prevention, so without having had a prior cardiac arrest, the likelihood of having an appropriate ICD shock was about 10%. So why does sudden death happen in HCM? And we believe it's a result of the ultrastructure of the heart architecture. So the disorganization of the muscle structure, what we call myocyte disarray. So the heart muscle cells are not neatly arranged in parallel, but are haphazard. And that leads to fibrosis or scarring inside the heart muscle that can lead to arrhythmia. So panel A is an example of normal heart muscle cells that are not affected by HCM. And panel B and C in greater magnification are HCM tissues that are disorganized. And in panel D in blue color, those are the sheets of fibrosis that kind of replace normal heart muscle cells and can lead to a short circuit in the electrical conduction and to dangerous arrhythmia that can potentially be deadly. So who is at risk for sudden death? First of all, let me introduce the idea of the defibrillator. So in 2020, there are two kinds of defibrillators. On the left side is the more traditional one, the transvenous device that sits under the left collarbone and has leads inside the heart. And this is a device that can function as a pacemaker also. Or the alternative on the right side is a newer device that is called a subcutaneous pacemaker. It is completely outside of the chest, and it has leads that are tunneled under the skin, and this device doesn't touch the heart at all. So choosing the right device for the right patient is an intricate question, and it's a very individualized decision that involves the patient and the clinician, and I'm happy to discuss this in a breakout session afterwards. So now, who should get an ICD? First of all, survivors of sudden death events and those who have episodes of sustained ventricular tachycardia on Holter monitoring. So those are defined as 30 seconds or longer. So in these patients, the rate of appropriate discharge, meaning a saved life, is about 10% per year. So this is an example of an EKG from a young man, 22 years old, who went to an urgent care center because he wasn't feeling well. And he had this EKG. It shows monomorphic ventricular tachycardia at a heart rate of around 250 beats per minute. Luckily, he's young and otherwise healthy, and he was externally defibrillated and then brought to our center, where he had this echo. So he has mid-ventricular HCM, so he's got thick walls in the middle of his left ventricle. And here in the middle, his obstruction is right here in the center. And the obstruction caused a large akinetic apical aneurysm, which is one of the strongest risk factors for sudden cardiac death. He received a defibrillator, and thankfully he's doing well. So now let's talk about the ICD and a primary prevention of sudden death, meaning in somebody who's never had a sudden death event, and hopefully never will. So there are 7 risk factors that have solid scientific footing and that we use. So any one of these markers will be a marker of increased risk for sudden death. So first of all, a family history of sudden death in a first-degree relative that we think is definitely or likely due to hypertrophic cardiomyopathy. A left ventricular wall thickness of at least 30 millimeters. That's a very thick heart. Fainting episodes that are likely occurring due to arrhythmia and not due to obstruction or other reasons. Non-sustained ventricular tachycardia on Holter monitoring, so those lasting less than 30 seconds. Extensive fibrosis, so cardiac MRI has gained an important role in the care of patients with HCM in the last few years. And we define that as late gadolinium enhancement of more than 15% of the left ventricular mass. And then when HCM transforms to a weak heart, so when the ejection fraction drops below 50%, and as I showed you before, an akinetic apical left ventricular aneurysm. So if you have any one of those, the rate of appropriate ICD discharge is between 3 or 4% per year. So what about age? Counterintuitively, the incidence of sudden death in HCM decreases with age. And age of 60 or older may be protective against sudden death, even in the presence of risk factors. So the decision to implant, again, is a judgment call. And at this point, I really want to drive one point home. Guidelines and recommendations are really just that. They can't substitute for clinical judgment, a thorough discussion of risks and benefits between patients and clinicians, and shared decision-making is key. Talk to your doctor. Here are a few examples of risk factors that I talked about earlier. So this is a young woman in her 20s, and this is an apical 2-chamber view on echo, and her basal anterior wall kind of looks funny and thick on here, and it is difficult to measure on echo. So MRI confirmed that this area was thicker than 32 millimeters, something that was not immediately apparent on echo. So she got a defibrillator. She also had extensive late gadolinium enhancement, so fibrosis or scarring on MRI, quantified at 21%. And on the right side, I'm showing an example of non-sustained ventricular tachycardia on a loop recorder. So here, the diagnosis of HCM happened backwards. First, a loop recorder was implanted where you can see the normal heart rhythm. And then suddenly here, the heart rate speeds up and the complexes look wide and different. That's ventricular tachycardia. And in this case, after this was found, the patient had HCM diagnosed. So let's talk about cardiac MRI again and why it's so important in the contemporary management of HCM. Here's a young patient in his 30s. His main phenotype is his main manifestation is atrial fibrillation, one of the important pathways that Lisa showed earlier. So here in his anterior wall and in his septum, he has very extensive foci of this white contrast enhancement, and that's scarring, that's fibrosis, and the percentage was quantified as very high. It's more than 50% here. And he was recommended to have a defibrillator. So about 50% of people who have HCM have some degree of late gadolinium enhancement. So the presence of that alone is not enough to discriminate risk, but the amount or extent is. So in this study, it's another landmark study from 2014, more late gadolinium enhancement meant more risk for sudden death, and that translated into more appropriate ICD shocks. So more enhancement, more sudden death, more ICD shocks. I do want to briefly talk about the European Society of Cardiology model. Researchers in Europe have developed and promoted a data-driven model. It's basically a calculator app where you input variables that came out of their model, and it gives you a 5-year risk of having a sudden death event. We don't use it as much here because it does not include all the 7 risk markers that we care about, and it tends to miss some people who should have gotten a defibrillator. But that's another topic for breakout sessions. So how does this strategy work, the 7 risk markers? Here's a study by the group in Tufts. It included about 2,100 patients with HCM over a 17-year period. Defibrillators were implanted in about 500, a quarter of this cohort. And the proportion of patients who had an appropriate ICD shock, and which you could call a saved life, was 16%. There were 5 sudden death cases among those who did not have ICDs implanted. Of those, 2 refused, 2 did not have any of the 7 risk markers. And 1 had an apical aneurysm at a time when we had not yet recognized that that's a high risk marker. So the 5-year probability of having an appropriate shock was 10%, which, if you think about it, 10%, 1 in 10 is pretty high. For every 1 prevented sudden death, about 6 ICDs were implanted. And the sensitivity was very high. So 95% of, like I said before, 95% of HCM patients who had an appropriate shock or who had a sudden death event were given a defibrillator. Now, if you applied the ESC calculator that I showed you earlier, only a third would have potentially been saved. And again, this is a topic that is hotly debated. Now, a few elements that do not influence the risk stratification. So first of all, the 12-lead ECG, although there can be pretty bizarre patterns on a 12-lead EKG, there's no association of those patterns with sudden death risk. Neither do invasive electrophysiology studies. So these are invasive procedures that tickle the heart with catheters. And there's also not enough evidence at this point that genetic testing that showing a pathogenic variant has any influence on sudden death risk. On an unrelated note, unfortunately, drug therapy, such as with beta blockers or even with antiarrhythmics, these drugs have not been found to affect sudden death risk. So only ICDs do. So what are the risks of implanting a defibrillator? We summarize them as quote unquote 6 I's. So the risk of implantation, so bleeding, infection, pneumothorax, injury to the heart. Those are the risks of the surgery, the procedure of putting it in. Then device infection, long-term infection, whether it's the pocket or endocarditis, an infection of the lining of the heart or the valves. Then inappropriate shock, so getting shocked by the device for a rhythm that is not life-threatening, for example, atrial fibrillation. Imperfection, so that's, device, defibrillator is a man-made device. Man-made things are not perfect. It needs a battery change after 7 to 10 years. The leads can fracture or get displaced. Devices have been recalled. And tricuspid insufficiency, so damage of one of the heart valves by the ICD lead. And then a so-called insurance risk. You pay into term life insurance, but you never need it. So that's the device that never goes off. A few words about quality of life. So the experience with defibrillators in ischemic heart disease, so cardiomyopathy from having heart attacks, in this group of patients, about 20% of them will die after having their first ICD shock. And that was a big question mark in the HCM community. But these patients die from other things. They die from heart failure or kidney failure or diabetes or other things that play into their heart disease, and not sudden death. And in HCM, that's not the case. And this study followed about 500 patients for 6 years, about 20% in an appropriate shock for a rate of about 4% per year. And they investigated quality of life, and they found no significant impairment in psychological well-being or quality of life. And here's my last slide. So what about the very long-term effects of defibrillators? This is a very recent study that was published last year by the group at Tufts. They included about 200 patients who've had ICDs for a long time, a mean of 12 years. And again, about 20% of patients in this cohort had an appropriate discharge. And what struck me here is that the minority of events happened in the first year. And if you look after 1 to 4 years, 24% of patients had an appropriate shock, more even after 5 to 9 years, and over 10 years after implantations, over a third of patients had an appropriate shock. So I often have patients who ask me, I've had the device in for so many years, and take it out. I don't want it anymore. I don't need it. And the answer, I think, is unequivocally no. So here are my take-home messages. Sudden death is a very important element in HCM care, and the ICD is a highly effective therapy to prevent sudden death. Our risk factor strategy is very effective at deciding who should get an ICD, and clinical judgment and shared decision-making are key. And thank you very much. And I look forward to speaking with you after Maria's talk.
I was on mute. Thank you very much. That was a great talk. I want to bring up one not very happy topic that's come up lately at the HCMA. And these cases really make me wonder, because I've been doing this for 25 years and this isn't new, this phenomena that I'm about to explain, but we've lost so many people who were told that they were high risk. And there is that shared decision-making of when to put a device in. No cardiologist that I'm aware of, or electrophysiologist in this country or others, can strap you to a table and put a device in you without your consent or the consent of your family if you're not conscious. But if you are awake and you are listening and you are told that you're high risk, but you're asymptomatic, you don't feel the risk, you don't feel the disease, it is far too often that is the group of people that we lose because they didn't act in time. I can go back to, there's a couple of cases that hit really hard. One was back in the 90s, and her tale is cautionary. She wanted to wait till she finished her master's program to get her ICD. Well, HCM doesn't wait. So when you've told you have a risk, I really think it's important for people to act upon it. And recently, the same situation played out again. I want to wait. So here we are 20 years later, and people are still waiting because they don't feel like they're at risk. What would you say to somebody who just doesn't feel like it's going to be them that has the cardiac arrest?
Well, I tell them this story. It's symptoms, especially symptoms of, from obstruction and your sudden death risk just don't go hand in hand. You can have no symptoms and be at very high risk, and you can have a lot of symptoms and need surgery and require a lot of care and treatment and have a pretty low risk. There is no risk. There's no such thing as no risk in HCM, but the two don't go hand in hand. And I don't know, what would you suggest?
Oh, I suggest for them to talk to other patients and to really think about what they could be giving up, and the minor inconvenience for a short period of time is well worth a long life ahead of them. Devices are not 100% effective. It's 99% or so. So there's always going to be that little bit of risk there. However, 99 point whatever percent is a hell of a lot better than, you know, not protecting yourself at all. So my heart was broken again last week with another one of these cases. So it's fresh in my mind, and the family is wondering what they could have done differently. And I think what they could have done differently was not have a false sense of security and understand that HCM is nasty and it steals from us, and we have to fight back. So that being said, I thank you very much, and I'm going to bring up our last speaker. The Q&A box is being used. We did have a couple of comments. I will go over them a little bit later, but Maria has been patiently waiting there. And we are going to talk about lifestyle and lifestyle changes in HCM from the nurse's perspective, and we're probably kicking a lot of the patient perspective as well. So let's share your slides and quiet my mic.
Great. Thank you, Lisa. Thanks again to you and your team for putting this together. And thank you, Dr. Sherrid, for inviting me to speak. So my topic is going to be on lifestyle modifications for patients who have hypertrophic cardiomyopathy. You know, we do focus a lot on the sudden cardiac death risk, and it is a significant thing that we need to focus on for our patients. But like we said, the vast majority do lead incredibly long and fruitful lives. And so with those long lives have the potential for comorbidities or other conditions that you can develop that just people develop even without HCM. So we're going to talk about a little bit how to manage those and hopefully prevent them. So I have no disclosures. We're going to talk about the difference between having an inherited condition and having a preventable chronic disease, how obesity can affect the hypertrophic cardiomyopathy phenotype, the impacts of these comorbidities I just talked about on long-term outcomes in HCM, how HCM influences lifestyle choices, and ways to prevent obesity and comorbidities to improve these long-term outcomes. So what does an inherited disease mean, right? So it's something that is genetic, it is hereditary. These terms are used interchangeably. A lot of times it's familial, you hear it's passed on through generations, and there's nothing modifiable about it. You can't stop it if it's going to happen. If you've already been born, you've already inherited those genes from your parents, or those genes have already changed while you were in development in the womb. So there's nothing we can do about those particular conditions. So very common conditions you might have heard about that are inherited are cystic fibrosis, Duchenne's muscular dystrophy, Tay-Sachs disease, and HCM. But we would like to point out that HCM is 10 times more common or just about than all these other conditions. So are they guaranteed to be inherited? No. For instance, for cystic fibrosis and Tay-Sachs disease, these are what we call autosomal recessive disorders. And you have about a 25% chance with each pregnancy of having a child with that condition. Duchenne's muscular dystrophy is an X-linked recessive. They have either a 25 to 50% of each pregnancy, depending on who the parental carrier is. And for hypertrophic cardiomyopathy, this is called an autosomal dominant disorder. And these are all genetic terms, which means that you only need one parent to be a carrier for each child to have a 50% chance of inheriting it from them. And just because they're carriers of the condition, they may not always be affected. There's about an 80% chance that you'll actually develop hypertrophic cardiomyopathy physically or manifest in some way, either on your EKG or echo. So it's not a guarantee again, but it is a higher predisposition. And severity can range even within the same family, which is why we're such advocates for family screening, even at the age as young as the age of 10, because even if one parent didn't find it till they're later in life, doesn't mean that their child may not find it earlier on. And we want to try to prevent some of those unfortunate circumstances like we just talked about. So a preventable chronic disease is what we call lifestyle preventable. So these are things like obesity, diabetes, coronary artery disease, and cancers. Are they all preventable? No, but a lot of them are. According to the latest data, about 42% of cancers are preventable, about 90 to 95% of type 2 diabetes is preventable. About 80% of coronary artery disease is preventable, and about 95 to 100% of obesity is preventable. And the reason that I put an asterisk there next to that 100% is because there has been recent inquiries on whether or not there is a genetic link to obesity, but no single genes have been identified at this time. So modifiable risk factors that we do have to help prevent these are smoking, not smoking, sedentary lifestyles or inactivity, poor nutrition, and excessive alcohol use. So what? So what does this mean about for HCM? So with HCM, if you are also obese, this can increase your left ventricular wall thickness, your left ventricular mass, and increase LVOT obstruction that we talked about. This also usually worsens your heart failure symptoms, such as increased shortness of breath, chest pains, potential fatigue. It can increase likelihood of developing systolic heart failure in hypertrophic cardiomyopathy where the pump fails. It also increases your workload on your bones and joints, which makes it harder for you to exercise, and it is difficult to differentiate what stops me first when walking down the street. Is it my body or is it my heart? How do other preventable diseases impact HCM? Well, coronary artery disease gives you a much higher risk of sudden cardiac deaths and events. It's also very difficult to diagnose in patients with HCM because a lot of those symptoms I just mentioned, as far as chest pain, palpitations, shortness of breath, can also be found in coronary artery disease. And diabetes and HCM makes you at a higher risk for cardiovascular events. You have a lower functional capacity and again, more heart failure symptoms. Cancer and HCM, while cancer itself, unless it's a cardiac specific cancer, typically doesn't affect HCM, but it's the treatment for cancers that can affect it, where chemotherapy can lead to electrolyte imbalances, medication interactions, radiation, depending on the location, if it's near your chest or your heart, can actually impact, there could be scar tissue that gets formed around your heart, which makes it even more difficult for it to pump. So then what can we do about it? Well, first and foremost, no smoking. If you are a smoker and you are our patient specifically, you've probably heard this every time you come to a visit. This is one of the #1 things you can do for your health. The Surgeon General is very clear on everything. Smoking definitely causes lung cancer and heart disease. These are 2 of those modifiable conditions that we can prevent. There is so much data out there now that has a direct link from smoking to coronary artery disease that is just so important for you to avoid. If you need help quitting smoking, you can go to plenty of resources online. I'm sure if you want to give us a call, NYU has plenty of resources to be able to help you quit today. We also get a lot of questions about marijuana and alcohol. So while marijuana has been legalized in 33 states for medical use and 14 states in this country for recreational use, there's still not enough evidence to support its use in patients with cardiovascular disease. It's metabolized in many of the CYP pathways, which can lead to popular drug interactions. A lot of cardiac drugs that we use every day for patients, even with HCM, antiarrhythmics, calcium channel blockers, nitrates, statins, warfarin, NSAIDs, beta blockers. Sound familiar? It's also found to be a very high contributing factor for young patients who have an MI without any other risk factors. So if you have a patient who has a child that has an undiagnosed form of HCM, this could increase their risk of sudden cardiac events from happening. Alcohol use as well. At our practice, we definitely try to encourage to limit the amount of alcohol that is used. It can cause vasodilation, which is opening up of the blood vessels and therefore worsen LVOT obstruction. It also, if you have too much, can dehydrate you, which can cause electrolyte imbalances, which lead to more arrhythmias. Hard spirits tend to do this a little bit more so than wine or beer. And there are also plenty of medication interactions that you want to be aware of when drinking alcohol. Many of them actually say to avoid it altogether. So talk to your pharmacist about that or talk to your providers. Weight management in HCM, weight control is just key in reducing multiple comorbidities, a lot of what we just talked about, and diabetes, hypertension, high cholesterol, heart disease. And diet is about 80% of the battle. You know, a lot of people have questions about exercise, and we're going to talk about that here in a minute. But what we don't understand is that the exercise is an addition to keep your body strong and bendable, because what doesn't bend will break. So for diet is the most important key to actually lose weight so that you can have more capabilities and more function in your life. And the diet, we'll talk a little bit more about what that might look like. We also have some really interesting preliminary evidence that weight loss can actually contribute to a reduced left ventricular wall mass and thickness. I submitted an abstract to the AHA scientific sessions this year, got accepted on a case series of 6 patients that had weight loss, significant weight loss, and we followed them before and after. We took images, just clinical images, and we reviewed them. And it turns out that they actually had an overall decrease in their LV mass and thickness. This is just one of those patients. This is to show you a picture. This is a CAT scan that we did because the MRI, because you can see this starburst here in all of the films is actually from her ICD. And so we were unable to do an MRI because it would otherwise cast a shadow over the heart. But here in this, you can see on the left side that this patient also had a myectomy already. And so she was still quite thick. Years later, still very symptomatic. She decided to go for surgery for bariatric weight loss. And this was her images afterwards. She had about a 6 millimeter drop in her septal wall thickness here in these images. Now, they're not perfectly to scale, but they are extremely close. And we had, similar outcomes with the other patients. So that's interesting. You can check that out, the HCA this year, and more to come from us on that. So the best diet that we feel we recommend to all of our patients is a low animal protein, plant-based whole food diet. You want to try to reduce or avoid foods that are high in cholesterol, like cheese, milk, eggs, red meat, dark chicken meat. You don't have to be a vegan. You could be a flexitarian or a plant-forward person. Proteins can be found in a variety of other foods like tofu, fish, quinoa, mushrooms, lentils, chickpeas, most beans and legumes. Even vegetables have a lot of protein that people don't know, like artichokes, asparagus, broccoli, Brussels sprouts. Now, a lot of these are green vegetables, so if you are on warfarin for atrial fibrillation, which some of you may be on, you definitely want to discuss that either with your provider or with us who manages your Coumadin levels so that they can be aware that this might be something you are going to try, and they can adjust your levels accordingly. But you want to make sure, sticking to this whole food, plant-based diet is important because even plant-based processed foods can be unhealthy. You need to avoid them because they have, especially usually very high in sodium or sugar. So you could actually gain weight by going on a plant-based diet because you're avoiding the things that help you lose weight. We all need carbs, okay? Let me repeat. We all need carbs. We're always trying to eliminate them from diets. We're always trying to reduce them. And Lisa, we need them as a part of a balanced diet, but what you want to try to avoid are simple sugars like added white sugars, brown sugar, syrup, corn, fructose, and dextrose syrups. Instead, choose complex carbohydrates in moderation, potatoes and whole grains, oats and fruits and vegetables. They are good for you in moderation. And let's talk about the importance of staying hydrated. Okay, water is your best friend. There's Lisa's glass. Here's my glass. It's so very important. Patients with hypertrophic cardiomyopathy, whether you have obstruction or non-obstructed, your ventricles are very small on the inside, and you really need to stay as plumped up as possible. So when you're in a low volume stage or you're dehydrated or anemic, the best thing for you to do is increase your water intake. If you notice that maybe during the summer, you're starting to feel a little bit more symptomatic, it's probably because you're losing more water than you normally do in the spring or the winter time, and you really need to boost up your water intake. That's probably the first thing that I would suggest to most of my patients when they start calling about those summer symptoms, as we call them. In the same thread, right, you want to avoid being out in those really hot summer days and avoiding those extremely hot environments. You know, when we are hot, what happens to our body is our blood vessels open up, they vasodilate to allow the excess heat to burn off, because your internal temperature should only be so high. So when that happens, the heart muscle contracts and it shrinks, which increases LVOT obstruction. It increases demand on the heart. So you really want to try to avoid those environments. This also, unfortunately, includes saunas, hot tubs, and jacuzzis. The temperatures in there usually are about 120 degrees if you go to a commercial jacuzzi or sauna. And this is just too hot for the body to handle. And you'll most likely feel symptomatic after coming in them. We have a lot of times people will call and say, I collapsed. Well, what'd you do? I got out of the jacuzzi, right? So it was almost guaranteed. So the exercise question is always a big one. And, you know, we might be having some, with the new guidelines that come out, these things might have been reevaluated or, you know, revisited. But for now, you know, we really stand by this diagram here, which basically starts from the bottom left corner, which is the most low impact and most safest exercise you can have for yourself, versus the one at the top right corner, which are the most dangerous and most concerning for patients with HCM. These have been shown to increase risk of sudden cardiac events. These are the kinds of activities that you find where these people are collapsing on the ground. So it's important to make sure that if you do exercise, that you talk to your provider on what kind of exercise is best for you and what's safest for you. We recommend that there's still a lot of exercise you can do. You can do the treadmill, you can do the stationary bike, you can walk, you can jog at a typical pace for short distances. You can go swimming, you can do light weights, no more than 60 pounds, or no ergonomic weights where you lift your own body weight, like push-ups and pull-ups. You want to avoid those things. You want to try to keep your heart rate below 120 beats per minute. You know, we advise that anybody who exercises to that degree to get a basic heart monitor so that they can monitor their heart rate when they exercise and make sure that it doesn't go up. You know, so that's important, because if you don't have one of those, then you're not going to know how high your heart rate is. And you don't have to get an expensive one. You don't need an Apple Watch, although they are good products. You know, you can get just a basic, you know, I have a Fitbit, you know, Garmin, there's all kinds that you can get out there these days. And you want to make sure that you stop for symptoms. You know, don't try to push through. Don't try, if you're starting to get seriously short of breath where you can't hold a conversation while you are exercising, you should stop and slow down. You know, this is not something that you are because you're out of shape. Now, that may be the case, but you also have a considerable effort being made on your heart. So you want to make sure that you allow your heart and give yourself some grace, that there are some limitations that you have. And in addition to that slide, in the last, 5 to 10 years or so, we've had some increased interest in the spin classes and hot yoga, high intensity interval training and CrossFit. All of these things we would put in that high risk category because it makes your heart rate come up very quickly and makes it fall very fast. And anytime that anybody is yelling at you, go, 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 push, 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 we ask you to no longer go to those classes and find something that's more relaxing and, just go at your own pace, because we don't listen to our bodies when we're listening to other people yelling. So in conclusion, if you have a predisposition because you've inherited a condition like hypertrophic cardiomyopathy, or your family members, this is important for families as well, that they may have a predisposition for inheriting this condition. We want to try and avoid all and any preventable chronic illnesses that we can. Keeping an ideal body weight can help prevent a ton of problems. I mean, I cannot stress that enough. It really helps to reduce the possibility of preventable chronic illness. And if you are overweight, losing weight will improve your symptoms. That's not instead of seeking medical treatment. That is in addition to your medical therapies. And heart healthy diets are key to reducing risk, to lowering cholesterol, to lowering hypertension, to managing your weight. All of these three things can help prevent diabetes, prevent coronary artery disease, and long-term outcomes improve. Hydrate, hydrate, hydrate. Again, water is your friend. Please stay hydrated every day. That amount is going to change depending on your activity levels, depending on the weather, depending on what you're doing that day, depending on your weight, it will change. So talk to your provider and ask them, what's the best amount of water for me today? And exercise is good, but within the guidelines. So don't overdo it. Don't push yourself, because it's not going to be good for you, even though other people might tell you it is. And always check with your provider if you're going to start a new exercise plan, so that we can help guide you and help, manage you and keep you safe. Thanks.
Maria, that was excellent. Thank you so much. You covered so many really important topics that really impact the patient's life and how we function every single day. The hydrate, 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 we've been chanting for years. I used to tease that it was the only medication that I was licensed to prescribe. Water, water, water. So water is good. So I'm going to go to the Q&As now, and our crack team here at NYU has been keeping up with your questions in the Q&A. In a few minutes, Julie is going to put, there's Julie, what, you were over my box here. Julie is going to post the meeting link in the chat box. And so go into the chat feature. Julie's going to copy in a few minutes and put the link to the breakout room where we're going to go talk privately and not be on Facebook anymore. And you can ask questions verbally on camera, or you can turn your camera off and you can just talk your questions in. We're going to be going there in a few minutes, but I'm going to go over some of the Q&As that were asked publicly. And I do want to take a few minutes to talk about COVID, because I was going to talk about that in the beginning and I got a little distracted with other things, and it's been a really crazy week this week. So number one, we do know that a number of people with HCM have come down with COVID through the HCMA. We know a great many of them. All of them in the United States have done very well. We had the opportunity to learn a little bit from our colleagues in Italy on how to get involved with care early. A few elderly people were lost in Italy with HCM, unfortunately, early in the COVID epidemic or pandemic. But we know that if you have symptoms, you really should be in communication with your HCM team when you test positive. There are a couple of anecdotal cases where people who happen to have HCM and happen to get COVID, happen to get myocarditis, and there are arrhythmias associated with it. So it's really important that if you do get COVID, that you're checking in with your team. Somebody on this screen had COVID and got pretty sick with it. Actually, two people on the screen had COVID and got pretty sick with it. One of them was on my team, but the other one was on the NYU team. Care to mention what that was like?
Not fun. I wouldn't recommend it. I mean, all things considered, I wasn't very sick, thank God. I was just, 3 weeks of, not really being able to do much. I'm healthy otherwise, and it was pretty rough. It was my first experience of being not well.
How do you feel, Doc?
Yeah, not good. It gave me an appreciation of what many people go through. But I think a lot of people got sick from exposures that we don't get these days anymore, thank God, because of social distancing, because of PPE, because of changed behavior, washing hands, wearing masks. And I cannot stress enough that these things are critically, vitally important. Protect yourself. Do not get sick.
Amen. Mark, Dan, do you have any comments to our population regarding COVID and what they should do and things that they should look out for? Mark, you're on mute. We're so good at going to mute so you don't hear our dogs barking and things.
I think we saw a spike in ICD discharges, perhaps because of stress. But we've had vanishingly few deaths. We've had some patients who got quite sick and were in the hospital. We've had one physician who was in the hospital quite sick, and who took a long time to get better, who had HCM. But as far as I know, I believe we only had one or maybe two deaths in the entire population of about 2,000 patients.
Not great to hear, but not horrible either. It can be survivable. I think the comorbidities probably play there as well. Was it just?
Yes. Oh, definitely. Yes, absolutely.
And that's the obesity.
It probably wasn't so much the HCM as it was the other comorbidities in that one patient I know who died.
Mm-hmm. Dan, if you're trying to say something, you're on mute. No? Did you? I thought you were saying something. Swistel, you're on mute. So continue, Mark. I'm sorry.
Hydroxychloroquine is something to be avoided. It's now been said to the FDA indicates that it's dangerous, but I think it might be particularly dangerous in a person with structural heart disease.
Good to know. Good to know. So exercise restrictions, we have some questions here. Jason's asking, you mentioned various exercise restrictions for people with HCM with max heart rates. Are there restrictions on activity after septal myectomy, or do they stay the same because you still have hypertrophic cardiomyopathy? Who wants to take that one? And whoever it is has to unmute themselves. Maria.
Well, we have one participant in our team who basically says after septal myectomy that you could do anything that you want whenever you want to do it. But there are
You eating Oreos? He's not listening.
Oreos are vegan.
They are.
There are others of us who disagree with that stance. So
This is Doctors After Hour, just in case you're wondering how goofy they can act. You're watching it. Okay.
Yes, it's exactly that attitude. Right. So the answer to your question is that I think that patients can do a lot more after myectomy simply because they don't have symptoms anymore. And they feel,
Right.
But we tell patients not to compete in sports after myectomy.
You still have HCM, you just don't have obstruction anymore.
Right. If you were to, Dr. Swistel takes out an area of the heart in the septum, but he can't operate on large parts of the muscle that still have HCM abnormal cells. And if you look at those cells under the microscope that are left in the heart, they're still abnormal. So, I mean, the patients definitely do more. They become much more capable of exercising, and they're much more fit because of that. But we still tell them not to push it.
So Maria, I'm going to ask you to send me, if I think I may have it already, your vegetable slide, because somebody wants it, and I will make it available on social media.
Yeah, I sent you earlier. Yeah.
Okay. So we'll get that one off to you, Joe. And Jason, we talked about that, so we're going with that. Should patients with HCM consider themselves to be at high risk of COVID complications? Unmute thyself.
Well, one has to be careful what you say here, because if I say that our experience has been good and that there's been not many patients who die, someone might take that as a license that you could do unsafe behavior. And I think that probably the reason why our patients have done reasonably well is they just have stayed at home. They've taken the warnings to heart. And I would encourage everyone who's listening to continue to wear masks, do social distancing, wash your hands, use hand sanitizers, and be careful, and don't let your guard down through the winter.
I think another piece to mention here in this high-risk classification, we still don't know a lot about COVID. Even the best epidemiologists and the best virologists, and we're still learning about this. So we know that a lot of people with COVID develop myocarditis. So it attacks the heart. So long-term consequences, I sadly predict we're going to have something called COVID heart later. We have rheumatic heart from rheumatic fever. And now are we going to have COVID hearts in 5 years, 10 years, 20 years? What is really happening here? And it looks like it's actually a potential to affect the muscle because of the myocarditis. And what are the potential long-term outcomes for myocarditis? Maybe you can talk to that a little bit, Mark.
Well, I think that there are people who are going to be following COVID patients long-term to look for complications. I think it's premature to know.
What does myocarditis do to the heart?
Well, it makes it more irritable. It makes it more irritable, and certainly any scarring that's added from the sort of sequelae of inflammation could lead to more ventricular arrhythmias. All I can say is that we're 6 months into the epidemic, and we haven't seen any big spike in HCM mortality. That's all I can say so far, at least in our patients.
I think that's a reasonable point of view. So please do be careful out there. Don't think, oh, I'll just get COVID and I'll be better in 5 days, because that doesn't really happen much. I know somebody else here who was affected, and it took many weeks, and this person doesn't have HCM. She just hangs around with people who do. So it was a rough road, and I offer, the caution to stay cautious and stay vigilant. We're going to do one more question here. So Julie can run away and go open the other room for Q&A privately. So we're going to do one more question here on atrial fibrillation, and then we're going to end the broadcast on Facebook, and we're going to go on over to the other room. What is the timeline? This is an interesting question. A timeline for AFib and HCM. Example, I'm 68, had weight loss surgery, been basically symptom-free for 5 years, but now we're having a couple of episodes of AFib. Is this related to my HCM or just age? Who wants to take it? Show of hands. Unmute your mic. Mark, Daniele.
So AFib goes up with age, and it goes up with the size of the left atrium. Above age 45 and above a left atrial size of 45 millimeters, many patients will develop AFib much more commonly. And I think the older you get with HCM, the more chance you have of getting atrial fibrillation. The atria dilates because the pressures in the heart are high. There might be mitral regurgitation. The heart's stiff, it can't fill, so the atrium gets bigger. And there's probably a myopathy of the atrial myocardium as well. I would just say that if you're starting to have paroxysmal atrial fibrillation and the episodes are lasting hours, your doctor and you might consider having a discussion about being on anticoagulation with a NOAC anticoagulant.
So I'm going to ask you an additional question, because this has been coming up the past couple of weeks. Watchman in HCM.
Yeah.
We're getting tricky here. So first, will you explain what Watchman is? And
Sure.
Second, I'm not aware of any trials on HCM at this point. What are you guys thinking?
Well, the first thing I thought you were going to say was watch, the Apple Watch.
That's a good point too. There's 2 watches in this.
There's not Watchman, but the watch. There's a trial that one of my colleagues is starting up to see the actual true incidence of atrial fibrillation over time by looking at the Apple Watch and using that to assess how often atrial fibrillation happens.
I will tell you, there's a Fitbit survey or study right now too that I'm actually in.
Right.
So it's looking at the same technology to see if they can use theirs for AFib detection.
Yeah, and it's important because sometimes the very first sign that a person has atrial fibrillation is the development of a stroke, which is tragic. They don't even know, these patients don't even know that they've had atrial fibrillation because they don't feel it, and yet they can present with a paralytic stroke. So that's going to be interesting to know. So then moving on to Watchman, which is a treatment. And Watchman is a treatment that's particularly useful in people who have contraindications to anticoagulation because they have bleeding, or people who have frailty or falls, and the person might be afraid to anticoagulate them. So Watchman, think of it as a plug to the left atrial appendage, which is where clots form. That's the selected part of the left atrium where clots tend to form. And then when they break off, they can cause emboli or stroke. So the Watchman's a plug. It's put in through a highly invasive procedure that involves putting a catheter across the atrial septum into the left atrium, sort of a catheter-based treatment, and putting up a metal device in the left atrium, and it seems to work. It seems to work, but like everything else that we do, there's complications. So it's very much of a benefit-risk ratio of whether a person should have a Watchman. And however, for people who can't take anticoagulation because they bleed, the Watchman is definitely a good idea to consider and to discuss, because I mean, strokes can ruin your whole day.
I know, I've been there. Okay, ladies and gentlemen, I'm going to invite you to go down the hallway, or also known as clicking on the other link. When you click the link in the chat box, it's going to tell you you're leaving the webinar. That's fine. You can leave the webinar. You're going to the meeting. So if we were in person and I'd say the breakout rooms are down the hall and I'd point you down the hall, I now point you down the hall. You can click on the link, leave the webinar, and I will see you over in the meeting room. And thank you to everybody who's been watching on Facebook. We hope you enjoyed this presentation. Check the HCMA website out at forhcm.org for more events, or look on the Facebook page for our events, and you can sign up for a future event. And hopefully we'll be back to doing this in person soon, but probably not till 2022. So we'll see you over in the other room, and I get to stay here till you all leave. So everybody just leave me. Thank you and good night.